Without oxygen, there is no life. This tutorial looks at oxygen solubility in the extracellular space and why it's important and how it changes when the partial pressure of the atmosphere changes. I guarantee you'll learn something. Fundamentals of Anesthesiology and Critical Care. With me, your host, Pat Nelligan. This is a course on understanding gases and vapors, and we're talking about the solubility of gases and liquids. This is part 3, oxygen solubility. In the previous tutorial, I discussed gas solubility, particularly with respect to carbon dioxide, and we looked at carbon dioxide solubility in extracellular fluid, and we looked at the impact of temperature on that. A key component of gas solubility is Henry's law, and Henry's law is all about how gases dissolve in liquids. And the law states that the volume of a gas dissolved in a liquid is proportional to the partial pressure of the gas above the liquid, the solubility coefficient of that gas within the liquid, and the temperature of the liquid. In this tutorial, we're going to look at the solubility of oxygen in extracellular fluid, the impact of 100% oxygen on extracellular fluid oxygen content, hypoxemia at altitude, and hyperbaric oxygen therapy. I previously showed you this particular table that demonstrates the solubility coefficient for oxygen, carbon dioxide, and nitrogen. And for oxygen, the solubility coefficient is 0.23 mils per litre per kilopascal, or in millimeters of mercury, 0.003 mils per deciliter per millimeter of mercury. Now, when I do the calculation, I calculate it as 0.03 mils per litre per millimeter of mercury. I also mentioned that oxygen is 20 times as soluble as nitrogen and 20 times less soluble than carbon dioxide. Gases dissolve in liquids along pressure gradients according to Henry's law. And the movement of gas stops when the partial pressure gradients equalize. Because gases pass easily through cellular membranes and are always trying to escape from the liquid, we measure pressures of gases within tissues in either kilopascals or millimeters of mercury. You can measure the quantity in millimoles per litre, but this is not conventional. There is a significant gradient between the atmospheric oxygen tension, that's about 21 kilopascals or 160 millimeters of mercury, and the alveolar oxygen tension of 13.3 kilopascals or 100 millimeters of mercury, and then again to the pulmonary arterial oxygen tension, remember that's venous blood, of 5.3 kilopascals or 40 millimeters of mercury. Consequently, irrespective of tidal ventilation, oxygen will diffuse along the pressure gradient from the upper airway to the alveoli to the pulmonary capillaries. Remember that in the alveoli, oxygen is in the gas phase and it's measured in kilopascals or millimeters of mercury, and in the bloodstream and the extracellular fluid, it's now dissolved in the liquid phase in kilopascals or millimeters of mercury. Looking at the oxygen tension in various components of the circulatory system in the tissues, we will just identify the components of the picture first. So we have alveolar gas, arterial blood, arterial and venous capillaries, the interstitium and the intracellular space, the mitochondria, and venous blood. The alveolar oxygen tension is about 100 millimeters of mercury or 13.3 kilopascals due to a small alveolar to arterial oxygen gradient of about 1.3 kilopascals or 10 millimeters of mercury. The arterial oxygen tension is about 90 millimeters of mercury or 12 kilopascals. There is a significant gradient between the arterial capillaries and the interstitium. At this stage, the PO2 in the interstitium is 30 millimeters of mercury, so oxygen flows very rapidly into the interstitium. That's 4 kilopascals. Then the intracellular space has a lower PO2 still, it's 10 millimeters of mercury or 1.3 kilopascals. Finally, oxygen must enter the mitochondria, and the mitochondrial PO2 is 5 millimeters of mercury or 0.7 kilopascals. The blood then returning to the heart on the venous side of the circulation has a PO2 of 40 millimeters of mercury or 5.3 kilopascals. Note that the oxyhemoglobin saturation is 99% on the arterial side and 70% on the venous side. This table demonstrates the different tensions of oxygen in the various tissue beds, and you can see there is a huge gradient from alveoli down to mitochondria. This is known as the oxygen cascade. The number that really stands out here is the fact that the arterial capillary PO2 is the same as the left atrial PO2. It's no different. And the reason why is because hemoglobin transports that oxygen from the lungs, from the alveoli, all the way down to the arterial capillaries. It's a transport mechanism. That delivery system neatly parcels up the oxygen so that it doesn't drift away. The hemoglobin then dumps the load, hopefully ensuring that the partial pressure of oxygen in the tissues is the same as the left atrium. And just like these lemons spreading on the ground, by the time they reach the edges or cells, the partial pressure has dropped considerably. Oxygen is not a particularly soluble gas, particularly in comparison with carbon dioxide, but you need to be careful. These numbers are a little bit misleading. High solubility of gases is not actually a benefit. Oxygen is consumed continuously and replenished. Carbon dioxide is produced continuously and eliminated. Nitrogen is completely inert. We inhale nearly 4 times as much nitrogen as oxygen. Despite the fact that nitrogen is 20 times less soluble than oxygen, our tissues are saturated with it, fully in equilibrium with the air, because that is the gas most of us breathe most of the time. As we will see later, that nitrogen can cause problems in certain circumstances. At this stage, I want you to try and confine these numbers to memory. Although oxygen is delivered to the tissues in a dissolved form, it is the partial pressure gradient that matters. In this cartoon, we have on the left arterial blood, in the middle interstitial fluid, and on the right intracellular fluid. The partial pressure of oxygen in arterial blood, as we have seen, is 12 kilopascals or 90 millimeters of mercury. In the interstitium, it's 4 kilopascals or 30 millimeters of mercury, and in the intracellular space, it's 1.3 kilopascals or 10 millimeters of mercury. Oxygen flows from the arterial blood all the way to the intracellular space. But because oxygen is really insoluble, it moves very, very rapidly along the partial pressure gradient. In comparison, carbon dioxide, because it is very, very soluble, moves extremely slowly from the intracellular to the interstitial to the venous space. So that carbon dioxide gets completely bogged down in the interstitium and it collects there because the partial pressure gradients are small and movement is slow. High partial pressure gradients and low solubility move gases to targets faster, and this is really important to understand how volatile anesthetics work. A patient is breathing 21% oxygen. How many mils of oxygen are dissolved in plasma? In the previous tutorial, I introduced an 80 kilogram male with a hemoglobin of 15 grams per deciliter. The plasma volume of this patient is 3.3 liters. That's the clear fluid component of the blood, and it's only 20% of the extracellular fluid. Let's calculate how much oxygen is dissolved in this person's plasma. Remembering that plasma is 50% arterial and 50% venous, and the solubility coefficient for oxygen is 0.23 mils per liter per kilopascals with a PaO2 that is usually 12 kilopascals. The solubility coefficient in millimeters of mercury is 0.03 mils per liter per millimeter of mercury, and the PaO2 is 90 millimeters of mercury. So let's calculate that out by multiplying the solubility coefficient times the pressure. So it's 0.23 times 12 or 0.03 times 90, and that works out at 2.8 mils of oxygen per liter of arterial plasma. But plasma is 50% venous, and the PVO2 is 5.3 kilopascals or 40 millimeters of mercury. So we'll multiply our solubility coefficient by our partial pressure in venous blood. That's 0.23 times 5.3 or 0.03 times 40, and that gives us 1.2 mils of oxygen per liter of venous plasma. If we add these two numbers, 2.8 plus 1.2, and divide by 2, that gives us the average amount of oxygen per liter of plasma, and we can multiply that by 3.3 to get what we have in total in plasma, and that is 6.6 mils. Not a lot of oxygen. To calculate how much oxygen is dissolved in the total extracellular space, we now need to calculate out how much is in the interstitium. The PO2 of oxygen in interstitial fluid varies from tissue to tissue, as you can see in this table, but the average PO2 for the entire interstitium is about 4 kilopascals or 30 millimeters of mercury. We can use this average PO2 for the entire interstitium to calculate the quantity of oxygen dissolved in interstitial fluid. Remember, our patient has 12.7 liters of interstitial fluid. So we multiply the PO2 by the solubility coefficient by the volume to get the amount of oxygen dissolved. So it's 0.23 times 4 times 12.7 or 0.03 times 30 times 12.7, and that works out at approximately 11.6 mils. To get the total quantity of oxygen in the extracellular fluid, we add in the value that we had for plasma, that was 6.6 mils, so the total amount of oxygen dissolved in the entire extracellular space is 18.2 mils. That is very, very little oxygen. Now, as an anesthesiologist, I routinely pre-oxygenate my patients by putting a face mask on the patient or equivalent at the beginning of the case and giving the patient 100% oxygen. This is done in ambulances, it's done in the emergency room, it's done all over. Does giving 100% oxygen increase the amount of mils of oxygen that are dissolved, for example, in plasma? Now, this has been extensively studied in volunteers, and I'm showing you this table because this is what the textbooks will show you. But we have clinically relevant data from our own practice that gives us better information about what happens with pre-oxygenation. This study looked at ASA physical status 1 and 2 patients breathing 100% oxygen for 3 minutes, either by face mask or by high flow nasal oxygen. And the median PaO2 was 49 kilopascals or 367.5 millimeters of mercury. With the face mask, with high flow oxygen, it was 57 or 427.5 millimeters of mercury. So I'm going to choose a rounding number of 55 kilopascals or 412.5, assuming that you've left the mask on for more than 3 minutes and that there's a good seal. So let's use this in our patient who's breathing 100% oxygen, 80 kilograms plasma volume, 3.3 liters, 50% venous, 50% arterial, and we multiply 55 or 412 by the solubility coefficient, and we just calculate out the arterial oxygen content, which is 1.65 liters. And that works out at 55 times 0.23 times 1.65 or 21.1 mils of oxygen dissolved in arterial plasma. Now, there's a fairly big drop-off in the PaO2 in venous plasma, and we're going to assume that it's 27.5 kilopascals or 205.3 millimeters of mercury and do the same calculation. And the result here is 10.5 mils in venous plasma. Adding the two together will give us 31.6 mils of oxygen in total in plasma. So that's a big, big, big increase. Now let's look at the extracellular fluid. Again, total plasma oxygen content is 31.6, and the interstitial PO2 is likely around 22 kilopascals or 165 millimeters of mercury. So we'll multiply these numbers out using the solubility coefficient, and that works out at 65 mils. So we're going to add together the plasma and the interstitial values, 31.6 plus 65, and that works out at 96.6 mils of oxygen in extracellular fluid in 100% oxygen. And these are the calculated numbers for your reference. But to be honest, this is just too much work, and this is a much simpler approach. The average PO2 in extracellular fluid in 80 kilograms given 100% oxygen, that's 16 liters of extracellular fluid, is 26 kilopascals or 195 millimeters of mercury. And you can work that out yourself. It works out very easily at 96 mils, or 6 mils per liter in extracellular fluid. Now that compares with a little over 1 mil per liter breathing air, and it just shows how much more oxygen you get into the extracellular fluid when you give 100%. It might not seem like a lot, but it is a staggeringly high partial pressure gradient. Let's change direction now. Has your PaO2 ever been 8 kilopascals or 58 millimeters of mercury? You're on an airplane and it has just reached cruising altitude of 35,000 feet. The cabin has been pressurized so that you can breathe. At 35,000 feet, you are 6,000 feet above the summit of Mount Everest. The atmospheric pressure outside the aircraft is 24 kilopascals or 180 millimeters of mercury. That is 1/4 the pressure at sea level. Remember, outside the aircraft, the FiO2 is still 21%, but the partial pressure of oxygen in the air, the PiO2, is 0.21 times 24 or 0.21 times 180, and that is 5 kilopascals or 38 millimeters of mercury. If you attempted to breathe air outside the aircraft, you wouldn't last long because the PaO2 would be 3.3 kilopascals 25 millimeters of mercury. Now, many of us, when we get on aircraft, feel lightheaded. I get very, very sleepy because airplanes do not pressurize the interior to 1 atmosphere. They settle for a pressure that would be the equivalent of 6,000 to 8,000 feet. And at 8,000 feet or 2,414 meters, the pressure of the atmosphere is 75.3 kilopascals or 565 millimeters of mercury. The PiO2, 75.3 times 0.21, is 15.8 kilopascals or 118 millimeters of mercury. At that pressure, the PaO2, taking into account the alveolar gas equation and a little bit of a gradient between the alveolus and the artery, would be 8 kilopascals or 58 millimeters of mercury. That's quite low, isn't it? Bet you're surprised. The airplane depressurizes and the oxygen masks deploy at this altitude. The oxygen mask can deliver 90 to 100% oxygen, but they're low flow and they need a reservoir bag. If 90% oxygen is delivered, what is the likely PaO2? Why don't you pause the video now and calculate this out yourself using the alveolar gas equation. The figures will be a PaCO2 of 5.3, a respiratory quotient of 0.8, and an A-AO2 gradient of 10 millimeters of mercury or 1.3 kilopascals. By my calculation, the PaO2 will be 58 millimeters of mercury or 8 kilopascals. And that is exactly what you were breathing before the cabin depressurized. Now let's visit the ocean. When an object is immersed in water, the pressure around that object increases progressively with depth. For every 10 meters of depth in the ocean, there is an increase in the pressure by 1 atmosphere. The Titanic wreck is at 380 meters depth, so the pressure at that depth is 380 atmospheres. Nuclear submarines can go down to a depth of 300 meters, but that is in an extreme situation. Recreational divers rarely go beyond 40 meters of depth. Most do not exceed 15 meters. Now, Nigel is a 57-year-old scuba diver. He's experienced and he's diving at 25 meters depth. But something happens and he panics. He rapidly ascends to the surface and he seemed okay initially, but 2 hours later developed various symptoms: confusion, chest pain, and numbness in his left arm. Nigel has decompression illness, or DCS. In this state, because of the rapid ascent, molecules of inert gas coalesce to form bubbles. This is known as outgassing, and the main inert gas in the body is nitrogen, so the blood turns to Guinness. The bubbles form microemboli and they start to obstruct blood vessels. Large bubbles compress tissue and there's activation of clotting cascades. This is life-threatening. Patients can have major strokes. They can have spinal cord injuries. Now, you might ask why it is nitrogen that causes the bubbles, but more soluble gases like oxygen and carbon dioxide do not. And the principal reason is that nitrogen is present in air at very high concentrations. It's completely inert, and the tissues of the body have been breathing nitrogen for the entirety of one's life, and as a consequence, the tissues are saturated with nitrogen. Oxygen and CO2 levels do not reach supersaturation levels required to form bubbles. The symptoms of decompression illness vary widely depending on where bubbles form and can appear in minutes to hours after a dive. There are really two types. Type 1, or moderate DCS, involves joint pain, known as the bends, especially in the elbows, shoulders, and knees. There may be skin rashes, itching, or mottled skin associated with fatigue or malaise. Type 2, or serious decompression illness, involves neurological symptoms that mimic stroke, numbness, weakness, paralysis, dizziness, headache. There is respiratory distress. This is known as the chokes due to bubbles in lung vasculature. And in severe cases, there may be cardiovascular collapse, particularly due to large emboli sitting in the cavities of the heart. In that situation, there is arterial gas embolism, where there is sudden loss of consciousness, major stroke-like symptoms, chest pain, and it may occur immediately after surfacing. Patients with type 2 or gas embolism need to be moved as soon as possible to a hyperbaric chamber. This is the hyperbaric chamber in our hospital, and it looks like the main cabin of an airplane. If you walk around and look inside, you'll see the seats where patients wear tight-fitting masks getting 100% oxygen. In this, the patient is recompressed or dived down to 2.8 atmospheres. That's 18 meters or 60 feet, and given 100% oxygen, and they're kept there for approximately 5 hours. Usually 30 minutes at 2.8 atmospheres, and then in slow stage steps, the pressure is released to atmospheric. This is called decompression. Natalie is involved in a house fire. There are no burns, but she's inhaled smoke and she is complaining of headache, blurred vision, and appears confused and slumping and falling over. She's given oxygen and her blood gas reveals a PaO2 of 50 kilopascals. She's given 100% oxygen, 375 millimeters of mercury. The saturation of the pulse oximeter is 98%. However, her carboxyhemoglobin is 37%. This is an indication for hyperbaric therapy because Natalie has carbon monoxide poisoning. Carbon monoxide has more than 200 times the affinity for hemoglobin as oxygen. It displaces oxygen from hemoglobin and can be easily missed because hemoglobin that normally binds oxygen stays red. So pulse oximetry appears normal, and the PaO2, the way we look at oxygenation, is also normal. The problem is that the hemoglobin trucks are now circling the body with limited oxygen attached. This is catastrophic for the oxygen cascade, and Natalie is manifesting signs of cellular hypoxia. So oxygen delivery is massively reduced. The treatment for this is immediate 100% oxygen therapy and referral for hyperbaric oxygen. The bends and carbon monoxide poisoning are both extreme injuries that require hyperbaric therapy, but it is used for all kinds of other things. So let's look at the physiology. In a person breathing 100% oxygen, we can use the simple approach to PO2, which we have averaged across extracellular fluid. So as you can see, the average PO2 in kilopascals at 1 atmosphere is 26 or 195 millimeters of mercury. And that results in our patient who we saw earlier on, who has 16 liters of extracellular fluid, having 96.6 mils of oxygen dissolved in his extracellular space, or 6 mils per liter. Now, once we give 2 atmospheres, there is a relatively large increase in the amount of oxygen dissolved in tissues. 52 kilopascals, nearly 400 millimeters of mercury, and a doubling of the amount of dissolved oxygen in extracellular fluid. The standard approach to hyperbaric is to go to 2.8 atmospheres, and the PO2 averaged across the extracellular space is about 80 kilopascals, or nearly 600 millimeters of mercury. The dissolved oxygen in 16 liters of extracellular fluid of about 280 mils, or nearly 18 mils in 1 liter. So these are the numbers that you kind of need to remember. Now, I calculated all of this stuff out, but realistically, this is what you need to know. The way that the dissolved oxygen increases very, very linearly in relation to the amount of atmospheres of pressure that are given. So the total oxygen in extracellular fluid at 2.8 atmospheres is nearly 1,500 mils. It's not massive compared to what we started with, but it should be enough to keep these patients alive while the carbon monoxide works its way off hemoglobin and while the patient is being recompressed and all those microbubbles are being dissolved back into the tissues. As a rule of thumb, the quantity of oxygen in blood and extracellular fluid increases by approximately 6 mils per liter for every 1 atmosphere increase in pressure. What are the indications for hyperbaric oxygen therapy? To reduce gas bubbles in air or gas embolism. You might see a gas embolism, for example, following the removal of a central line in the erect position, or for decompression illness, which is a very common indication for hyperbaric therapy, for carbon monoxide poisoning, for infection with anaerobic species such as gas gangrene and occasionally necrotizing fasciitis, for radiation injuries, and for chronic ischemic injuries, in particular where wounds fail to heal. So how does hyperbaric oxygen work in situations of poor perfusion and ischemia resulting, for example, in non-healing ulcers? Under normal conditions, all of our tissues are well perfused and oxygen diffuses along the oxygen cascade. However, in situations of chronically poor flow or ischemia, little oxygen is delivered locally to the affected tissues, and they're chronically ischemic. With hyperbaric oxygen therapy, well-perfused tissues become supersaturated with oxygen, and this rapidly diffuses into the ischemic areas and then into the cells, providing oxygen for metabolism, tissue healing, and regeneration. Let's review this tutorial. This was a tutorial about the solubility of oxygen in plasma and extracellular fluid, and we looked at the partial pressure gradients of oxygen from the air to the alveoli to the mitochondria. We looked at dissolved oxygen, the oxygen content of these different fluids, and then we looked at what happens with 100% oxygen. We looked at hypoxemia at altitude, and then we also looked at what happens at depth. We followed this by a short discussion about hyperbaric oxygen therapy for the bends, carbon monoxide poisoning, and for chronic ischemia. Next time, we're going to look at hemoglobin and the oxygen content of blood. I guarantee you'll learn something.